Yeah, so my name's Dr. Lani Roy. I'm the founder of the Science of Life Psychology, and I provide a range of services in the community. I've been working and supporting the Mental Health Foundation for nearly 9 years now, and just want to acknowledge all their incredible work that they do in the community, particularly for multicultural services and for supporting people with lived experience. And just a shout out to everyone at the Mental Health Foundation. You're dear friends of mine, and really looking forward to supporting the Wellbeing Hub and everything that you're doing. Over to you, Nigel.
Thanks, Alana. Welcome. As Lana said, my name's Nigel Denning. I'm a counselling psychologist, and I run a clinical practice in East Melbourne called Integrative Psychology, where we have a number of psychologists, psychiatrists and psychotherapists working. And I've been in this space for pretty much my whole adult life. I was introduced to the work of Stanislav Grof in my mid-20s by my first mentor, Alf Foote, who was a psychologist, a Methodist minister, and a holotropic breath worker. Quite a remarkable mystic he was, really, and introduced me to this work. And then after about 10 years, I had the opportunity to work with Stan Grof, and I've had an ongoing relationship with Grof transpersonal training now for about 25 years, I'd say, all up. So I'm also MAPS trained, having gone through their training. I've been running holotropic retreats for, as I say, 30 years. And whilst it's not actual medicine work, it's quite a powerful analogue for state change experience. But I'll just launch into the presentation today, and Alana, feel free to drop in whenever you like, in the spirit of a collegiate, collaborative working relationship. So the trial space, the clinical structure is that there are 2 to 3 dosed sessions of either the psilocybin or MDMA, depending on the structure of the trial. And this is seen as, the intervention. So rather than it being an ongoing, open-ended therapeutic relationship with kind of classical psychotherapies, this is a really time-limited and quite intensive kind of intervention. And one of the things we're kind of looking at is the fact that these medicines can actually be curative rather than palliative, that people can actually transcend the limitations of their suffering in treatment-resistant depression, treatment-resistant PTSD, and can actually experience new ways of being in their own body, being in relationship, being in the world, that can be permanent when supported and structured well. We don't say it's a panacea, so it's not going to work for everyone, and it's not going to work on all circumstances, but so far the results from these clinical trials are incredibly positive. So there are a great many people that have the potential to be helped when this work is done systematically, in a well-governed clinical and ethical framework. One of the strengths of these type of medical interventions is that they tend to be non-addictive. So we don't have the same kind of problems that people might have with, other Valium tricyclic type medications and things like that, where efficacy and dependence seem to, amplify as time, efficacy drops and dependence increases as time goes by. They've been designated with breakthrough therapy by the FDA, the American Food and Drug Administration, and that gives the opportunity then to fast track the use of these medicines to the public. So there's a fairly strong probability that next year MDMA will be a clinically available treatment for specific conditions such as PTSD in the United States. And there's a lot of work in Australia being done to make these medicines available as soon as we can. Psilocybin's probably a few years off, but there are large scale stage 3 trials going on around the world. So there's a certain sense of inevitability of these medicines being rolled out to the public. It's really just a matter of when now. And our job is to be prepared for it. Develop the clinical skills, develop the understanding, so that when they are available, there's a good level of clinical understanding, so that we can really make the most of opportunity as they arise. So people may be familiar with this idea of the default mode network. What we see in this diagram, it's a fairly famous diagram now that's come out of Imperial College in London. On the right, you see some brain patterning for people that have received a placebo, and on the left, people that have received a dose of psilocybin. What you see around the perimeter of the circle are a set of little dots, coloured dots. These are representing brain regions, and you see that the left and the right, these dots around the perimeter are the same. So we're suggesting that the induction of psilocybin isn't so much changing brain regions, but what you'll notice is the interconnection between the brain regions is incredibly rich and voluminous on the left-hand image, whereas a little more sparse on the right. The right is this kind of resting space that the human brain settles into. This is the theory of the default mode network, that there's a kind of an interconnection between thalamus, amygdala, and the medial prefrontal cortex, which is about the way in which we genetically and biologically adapt to the environment, and then frame that up as an awareness of who we are within the environment. So we create this sort of constructed sense of self through exposure to relationship across time. So when we say someone's in treatment-resistant depression, for instance, what we would say is that the default mode network is structured and rigidified in a particular way that is causing consistent suffering. If you want to get a sense of what the default mode network feels like, you just try and recognize when you're in a bit of a daydreaming state, you're not focused on anything in particular, that you're kind of just sort of drifting off and just staring out into space. That will be the default mode network as it sits with you. It'll be the way that your brain is oriented towards your body and to your body's experience across time. So when we talk about people in states of suffering, be it depression or PTSD, what we might hypothesize is that the default mode network is set in a particular way, as you see on the right. On the left, the psilocybin dose creates all these opportunities for connection. This is where the kind of the therapeutic intervention becomes so important in helping people to reset this default mode network, rest in a different way of experiencing themselves in the world in relation to other, following a positive experience under psilocybin.
Just add there, and I guess the power of the therapy to support this process is that once clients are finally lifted out of their rumination, of their trauma, of their self-limiting beliefs, it's very, very powerful to be lifted out of that, but then to be able to just stabilize that into embodied behavioral change, into actually longer lasting effects. This is where the container of the therapy really comes into play, so that they can be lifted out, but then stabilize into healthier ways of being.
Yeah, thanks. Yeah, we think this is a fairly structured process that we need to skill people around. So the formal interventions come a little bit after. So you've got something like 5 days of neurogenesis. It's a process of neuroplasticity when you introduce a medicine. So you've got this opportunity for new neural pathways to establish, as you can see in the diagram here, and to settle. And you've got about a 5-day window. So we think that the therapeutic interventions, as people are emerging from the medicine and in those first few days following the medicine, need to be a little bit different to the more structured narrativizing therapies that people would be more familiar with, your kind of standard intervention kind of techniques. So just some notes on the main trials that are going out at the moment, going on. Imperial College trial results recently published. Two sessions of psilocybin assisted therapy were effective in treating moderate to severe depression over the course of a 6-week period. Remission rates were twice as high with a psilocybin group to an antidepressant group, and the effects were quicker, and the magnitude of change was greater. So we're kind of starting to see that there's real positivity in this work being done well and being done in a structured way. And similar kind of outcomes are coming from the MAPS. That's the Multidisciplinary Association of Psychedelic Studies. That was established by Rick Doblin around about 1986. So Rick's been a real warrior for this work for 3 decades now, almost, in trying to forward clinically controlled and well-governed work in MDMA. The original research was done by Michael Midhofer and his wife Annie, who performed the phase 1 trials, and now we've gone to and completed phase 3, which have all been published. And we're looking at 67% of participants who received the 3 doses in this case of MDMA assisted therapy no longer qualified for a PTSD diagnosis, and that's on the CAPS-5, which is the gold standard of assessment for PTSD. And 88% of participants experienced a clinically meaningful reduction. And this extends. This is not, they don't go into remission, immediately after. They seem to hold this this change quite positively at the 12-month stage. And we're talking about people that, as I said, are treatment resistant. People suffering from PTSD. So they've tried medical intervention, they've tried psychological intervention, and nothing has worked for them. So they go into these trials, and we're getting these quite extraordinary positive outcomes. Again, let's keep the lid on it, because there are a percentage of people that aren't helped. Small percent, but it's still significant. So, as I say, there's a lot more work to be done to understand why this medicine works, and how we can best support it, and how we can best utilise it. But you can see here that it's incredibly positive in these early phases.
And just to add there, Nigel, I'm really curious about trials evolving to include the aftercare beyond the therapist. So, what are the community interventions and support groups, and I guess the community container that can be supported after the clinical trials? Because I'm imagining for many people, once the therapy's over, they've had their time with the therapist, there's still that deep need for ongoing community, and I'm really looking forward to seeing how the trials incorporate that further.
Yeah, well, I mean, that's really not something that the trials have been focused on, as is the kind of the issue with clinical trials. They're about confined and contained process. So I think what we're talking about now is sort of looking at ways to connect people, to train, to provide supervision, to provide support groups for people that have had exposure to this medicine work through trials or through any other mode of exposure. I think it's really important that we start having really clear and open community conversations about it. Certainly we provide at Integrative Psychology, Lani provides these types of supports, and there are many people out there, and we're really sort of trying to reach out to establish a good, well-governed community of people who are aware and understanding of these processes. Mind Medicine Institute is involved in providing these supports as well. It's a really important part of the work, and we're in the early stages, but it's going to be necessary to hold an open and aware community, particularly when this starts to evolve into a broader clinical practice. So you can see here just the way in which, even at 6-month follow-up, improvements for treatment-resistant depression have been sustained. So we're looking at sort of a hopefulness. So people aren't needing to return to the medicine over and over as they might do with the way that we've now We've been using SSRIs, for instance, for about the last 20 years. We originally, with SSRIs, saw them as an adjunct to therapy. They tend now to be seen in many places as simply a therapy in themselves, and they tend to be long-term. So you can see here on 2 doses, we've got a continuation of improvement at the 6-month stage for depression symptoms. So just a little bit more detail about the MAPS trials, and making it very, very clear that MDMA is not ecstasy, that MDMA is a clinically produced pharmaceutical that is given under very clearly defined and very well governed and protected clinical sort of circumstances. And just a little bit there about the phase 2 trials, where we're looking at, again, high levels of remission and continuing remission at the 12-month follow-up at 68%, which continues into the larger phase 3 trials. One of the interesting kind of orientations to psychedelic assisted therapy and the role of these medicines is, if you see, and this is a reasonably well-known diagram now, it's just contrasting the relationship between the action of SSRIs and the action of MDMA. And you see that in the SSRI at the top, that you get you get this increase in postsynaptic signaling of the 5-HT1IR neurotransmitter. Limbic responsibility decreases, so you're getting this blunting of affect occurring. You're getting a reduction then of stress, impulsivity, aggression, and anxiety. So this is a reduction that occurs through a blunting of these processes. So it increases resilience because people are not as reactive and responsive. Whereas with the receptors in the MDMA, you're getting this increase in cortical entropy, you're getting a reduction in rigid thinking, and you're getting an increase in environmental sensitivity and emotional release. So what you see with the MDMA is a process of upregulation. And that's where it's sort of consistent with what you saw in that earlier image of all of the brain regions being connected. What you're seeing is the introduction of possibility in the lived world of the patient, rather than the reduction of negative features as you would experience in the SSRI medications.
Just to add there, Nigel, just how powerful MDMA can be as a empathogen, as a heart opener, particularly for people with PTSD and sexual abuse trauma, to be able to feel safe whilst they process feelings of shame and flashbacks and the warm container that it provides and relationally with the therapist as well.
No, that's a good call, Alana. What we're really talking about in this as a therapy is the need in the preparatory stages before people experience the medicine, that trust, safety, that these kind of features are established. This is where the therapeutic relationship becomes really important for the introduction of a medicine, that we're creating safety. We're creating this sense of trust in order for people to have a different experience of themselves, and other. Because most of the trauma around PTSD is trauma that's occurred in people's relational field. They've been brutalized by others. They've been attacked by others. They've been hurt by others. So the idea of relationship is it stimulates a fear response. It's one of the features of PTSD. So creating this trust and safety, and then amplifying that through a medicine, and having the therapists support the safety of that process is absolutely transformative. And if we mark this well in our work with integration, then that person becomes empowered, that person becomes autonomous, that person becomes more emotionally fluid, and holds what Anthony Bateman describes as epistemic trust, which is a deep embodied felt sense of trusting in the world, not naively. You still have all your features of, observation and discrimination, not kind of turning life into a kind of an endless sort of bout of lovingness, even though that might well be a nice way for the world to work. But we have to be realistic, and it's all about, holding that trust internally, just really owning that as something that is your own. So different terms that are used: psychedelic, hallucinogen, entheogen. We sit with psychedelic in the work with psilocybin, LSD, ayahuasca, these sort of classic medicines. Hallucinogen has, we believe, a little bit more of a kind of a pejorative kind of link. It's really something that's linked to the kind of the symbolic rupturing associated with psychotic fantasies and delusions. So we kind of prefer to keep hallucinogen as something that's linked to hallucinations and something that's really in the clinical domain. Psychedelics are more kind of empowering, we feel, term. Entheogen is another synonym that's used for these medicines. And that really has a kind of a deeper linkage to ethnomedicine and the way that Indigenous cultures hold sacrament through these medicines. So, we prefer that entheogen is applied more to this sort of anthropological understanding of the way in which cultures hold these sacramental medicines. And so psychedelic simply becomes something that is sort of suited to our Western kind of sensibilities, understanding that there are many other ways of holding these medicines in different cultures. These medicines have been used forever, and it doesn't take a lot of digging to find examples of medicine use at the base of most experiential spiritual traditions. Hindu, Christian traditions. There are suggestions of various types of use of plant medicine. The Greeks famously used it in their Pythagorean mystery schools, and it was part of an annual ritual for the attainment of wisdom and knowledge and understanding. In modern times, we see the introduction of LSD, the synthesization of LSD by Albert Hofmann before the Second World War. Merck had developed MDMA even earlier, and then in the 50s and 60s we saw the explosion of interest in psychedelics and empathogens. One of my mentors there, Stan Groff, famously said that psychedelics used responsibly and with proper caution would be for psychiatry what the microscope is for biology and medicine, or the telescope is for astronomy. So this is really what he's pointing to, is the way in which these kind of medicines can be used to explore the self, explore the way that the mind works and the way that the mind operates. And so we had this terrible period of complete shutting down of research, and now we've got to the point where the Canadian government now allows terminally ill people to use psychedelic assisted therapy to ease death anxiety as a beginning of a reintroduction of these medicines to our culture.
Just acknowledging there that altering our states of consciousness is very inherent in being a human, and I think it's not held very well in Western society, particularly in younger populations and teenagers, the desire to shift consciousness and to explore consciousness. And there's a real lack of leadership and elders in our Western society around how to do that. So as this emerges in our society, in the clinical space, but also in the community space, just really calling in strong leadership for preparation, for integration, and for teaching people that it's natural to alter consciousness, but how do you get the most out of it? How can you stabilize and ground once you've done that?
Yeah, thanks, Lana. I mean, the model we use is, we look at, the medicines create a state change, but how do you turn that into a stage of development? And in the West, as Alana's pointing to, we've kind of forgotten that we keep developing. The West has sort of taken a kind of Piagetian approach to development, and sort of this is sort of pre-formal operational stage, which is just a little above, concrete operational. In other words, the mindset of a 16-year-old is seen as the high point of our development in our culture now. I hope that doesn't scare anyone. So we're really kind of encouraging kind of a more systematic view of what the developments of adult consciousness need to look like if this species works in the direction that it needs to avoid an evolutionary catastrophe. We need to evolve our thinking into higher order reasoning, higher order connectivity. We need to start to understand that we are a singular species, and that this singular species is embedded in a singular ecology. If we don't sort of start moving towards that level of understanding, we're going to have problems. And it's interesting when people report positive outcome from psychedelic sessions, they've often contacted this higher level of awareness, this interconnected level, sometimes described as the numinous. But it's this sort of natural kind of orientation towards being connected to your body, or being connected to other, or being connected to family, community, culture, environment. These kind of ways of seeing the world are not common to Western culture, where we kind of collapse into individuality. The classic psychedelics are LSD, psilocybin, DMT, mescaline. The entactogens, which I think is Bill Richards' term for them, or the empathogens, MDMA. And then we've got this other kind of interesting group of medicines where there is quite a bit of ketamine work being done around the country because it's prescribable. It's off when used for therapeutic purposes. It's an off-label use, but it is possible. Has a very different kind of feature to psychedelics or empathogens, but it does have a very intense and short-term state change kind of quality to it. So it does allow us to do some work in non-ordinary state. Caparotid dissociatives are ibogaine and salvia divinorum. Ibogaine as well is an available medicine, but used typically for addictions work. But a very intense journey, so needs to be used very wisely.
And just briefly, I've started doing some ketamine assisted psychotherapy work legally here in Australia, because social workers are currently allowed to do that work. And as Nigel mentioned, it's very different from for example, an MDMA or psilocybin session, which is typically a lot longer. It's very fast acting, brief, but what we're noticing and what the literature is kind of pointing to is that there's the potential for, I guess, from an IFS perspective, for protectors. So for structures that hold people's systems in place, the defense mechanisms to really loosen and, dissociate from your dissociation. And in that, there's a huge therapeutic potential for actually working with the repressed trauma. So it's been really incredible to see even how an hour of ketamine administration, what that can create and open up in the therapeutic window afterwards.
Thanks, Lana. Yeah, it's a falling away of this default mode network, this rigidity of response, and the opportunity to create new pathways. So this is a study that got David Nutt sacked from his job with the British Health Commission. I'm not sure what the actual title of the organisation is, but a large study into trying to amortise the harm done by various chemicals in society. And what got him into trouble, if you look at the bottom of the list, is the relative lack of harm that's being created by the use. And we're talking about, the non-clinical use here. We're talking about, and we're not advocating for, underground use or doing this stuff, socially. But when it is used, we can see that the level of damage is incredibly lower than something like alcohol or heroin or crack cocaine or tobacco. So whilst we're not saying they're completely safe, please don't misunderstand me there, their relative risk is quite low when they're used in a non-controlled environment. So when we talk about then good clinical governance, then we can really reduce the harm factor to very, very low levels of possibility. So there's a real kind of opportunity here with appropriate use of these medicines. So trial protocols, as I've mentioned, have been going on for a number of years now during this renaissance of interest. Some take the pathway, and this sort of responds or reflects on particularly the early work done through the Imperial College in London, which were neurologically based protocols. So really looking at the way that the medicine affects the brain, and that's the primary interest. So seeing if it is solely a medical intervention, then we move into what would be more reflective of the MAPS training, which is using MDMA protocols with a supportive therapy. They are not focused on any structured kind of therapeutic intervention. However, what we would argue is if we look closely at what happens when it's done well, is there's a lot of micro behaviour that goes on in the therapy that is all about following the patient and supporting the patient and attuning to the patient's needs and wants, which requires a significant amount of preparation work, assessment work, and integration work. And then we look at the more recent kind of proliferation of protocols that employ psychological therapeutic structures. So people are now starting to look to pairing medicine with a particular psychological intervention, such as one of the most popular at the moment is ACT. People are using EMDR, CBT, internal family systems. There's a number of different therapeutic protocols. And what we might suggest gently to people is that these protocols, these therapeutic tools are really good for integration work post neurogenesis, but can be a little too impositional during those really early phases of recovery from the medicine session and this sort of neurogenesis process, this new pathways. They're best explored at the level of the individual's subjective experience, but well supported by care and attunement. Then you move into your therapeutic tasks. That would be our kind of argument around this work. But as you can see, there's kind of three broad areas that the trials follow. This just shows that there's a really clear drop-off in research, and then just in recent years, a real kind of amplification of research. So we're working in the right direction right now. Talk for a moment about the treatment model that we're suggesting would be a really interesting way to approach this work, and it's really based on just integrating the different trial protocols into a singular kind of suggested structure, which involves detailed assessment, intake. So people are referred in. You do some good screening at the intake level, because there are some people that are not appropriate or are not in the right stage of life, people who have really poor reflective functioning, people whose lives are really unstable, people who are in a process of active addiction, people that have a psychotic illness. These are probably not the best candidates for this kind of treatment. We do an intake, then you do a detailed assessment, and part of the assessment is really getting a detailed understanding of the lived world of the patient. You really need to know developmentally what their challenges were, what's worked for them, what things were blocked, what things were encouraged, because what you want to be able to do during a medicine session is have a degree of prediction about what might emerge, and then and also a bit of a template to interpret what has emerged. So we do preparation sessions after assessment, and that's where we're really working on the trust, the safety, starting to demystify what might happen, what might be the limitations or strengths of a medicine session, work with the patient's fears, expectations, talk about what what problems they might anticipate and how to manage those. We then have a psychedelic session in which we suggest two therapists be present. We allow, up to 8 hours, depending on the medicine. It could be longer, depending on some medicines. Then we're doing integration. We start integration immediately at the cessation of the medicine. We then work with integration in that 5-day window, and some contact on a daily basis is usually the best idea, but possibly not a full therapy session. And then after that, we go into the stage of integration where we would start to use our therapeutic tools. Then we go into another preparation for another round of the psychedelic medicine. Again, integration, come to a formal conclusion of therapy in which you really come up with a plan for ongoing work. So for some people, that might be it. That's enough for them and they've got what they need out of it. For other people, there may be some kind of referral to ongoing integration work through more traditional therapeutic means and protocols. Always good that people that are conducting that therapy have an understanding of the nature of psychedelic assisted therapy and what the person's gone through, particularly around the new possibilities and new opportunities. And then we're just suggesting that we have follow-up just to ensure that the integrity of the work we're doing and to check the safety. So that would give me a pretty broad overview of what we're doing and what we're trying to teach people. So thank you, Lani.
Yeah, awesome. Thanks, Nigel. So you can close down that screen if you like, and we've got a question from Alex, and it says, Nigel, you mentioned treatment-resistant depression and PTSD. Have there been studies on the use of psilocybin for treatment of bipolar disorder and its effectiveness?
Well, have there been studies? There have been some studies on bipolar disorder. I think Dr. Lani Roy has been involved in something to do with bipolar and ayahuasca at one point. Yeah, there are. There's proliferation of pretty much any presentation now is being looked at in the trial space. One of the ones that people aren't looking at the moment is psychotic conditions, but that's what Stan Groff's early work with LSD was all with people with psychotic illness. So when we get this worked out and we get our process and procedures and our understanding well, I think we'll see pretty much all conditions will be open to some kind of treatment with these medicines.
So I'll just add to that. I work with a lot of people in the harm reduction space in the community who have bipolar, some even schizoaffective disorder, even dissociative identity disorder, and BPD, borderline personality. But it is complex and it requires a lot of holding, a lot of preparation, a lot of support around the person. And Dr. Benjamin Mudge is someone with lived experience with bipolar, and he is doing his research and PhD in this area. So he's got some great resources if people are interested in looking for Dr. Benjamin Mudge. But I guess the main step in that work is that the person has to have a strong connection with a community or a therapist, because they already have a disorganized mind or lack of as Nigel Tray would frame it, limited metacognitive capacities. So starting with, I guess, more gentler psychedelics, or even CBD and THC initially, and then MDMA, then potentially mescaline before going to ayahuasca and psilocybin, because it can lead to further fragmentation of their mind if they don't have an ego to return to. So yeah, lots. I could talk for hours on that topic because it's my favorite. But yeah, there are people in the community doing this work, but there's also huge potential risk for it to go wrong because of the added complexities of the mind.
I mean, interestingly, Stan's early, his PhD was based on high dose LSD for people with psychotic and bipolar disorder, but they were contained within a hospital in a research facility that was well governed, well managed. So it's there's so much for us to explore in this space.
Often the clients that I talk to, who want to get into these clinical trials, but then might be excluded at this point, they're used to high levels of distress in their mind. So for them, for the ones that I've spoken to, they're not scared of the medicine. They need the container. They need the therapist, the assessment, the preparation. So I think just being mindful that people with lived experience have gone through a lot, and yes, we need to protect them, but it's more, in my sense, the container of the aftercare as well, and the preparation.
That's a really good point, Alana, and that's something that we kind of really bring through the training as much as we can. The impact of psychology, psychiatry over the last 100 years is to focus on negative state, and it's to focus on the containment of negative state in order to keep people alive and to reduce symptoms to make people more capable to navigate the world, but it doesn't allow for growth and transformation and transcendence. So that's where we'd say we need to start thinking a little bit differently about what we're doing in the psychotherapy space, because keeping people alive is obviously our primary goal. And so I wouldn't say abandon the focus on negative state, but we need to start to kind of get the balance in a better order, so that we look for opportunity, we look for growth, we look for new potentials that I said earlier is one of the main benefits of, particularly of psychedelic medicine, is the experience of new ways of being. And so we need to be attuned as therapists, not just to help to mitigate the negative, but to also encourage the positive. And it's quite a shift in therapeutic kind of orientation.
And Samantha's asked to say a little bit more about psychotic conditions. Is there anything else you wanted to add, Nigel?
About psychotic conditions? Well, I only that they're really a contraindication for the type of trial work that's going on at the moment, because with psychotic conditions, they're usually a consequence of a degree of disorganisation of self, and so people need to have some reasonable reflective functioning in order to amplify disorganisation, which is what often occurs in a medicine session. The ordinary structures sort of dissipate and new possibility arises. And sadly, that's often what people with psychotic condition are living. So stabilisation for them is probably the best idea.
And also just being conscious in the harm reduction space when people take medicine. So if obviously sleep deprivation can really tip people into mania. So it's encouraged for people to be having, day ceremonies as opposed to staying up all night, which could then elevate mania. So there's different harm reduction strategies that you can, work on with the therapist around, limiting, a chance of mania. And I guess it's also really important to mention in the trials and also in the community space that anyone that's had a recent suicide attempt, normally within 6 months, is even in shamanic circles, is really kind of discouraged from engaging in medicine, because there's not enough internal stability to hold what could then be another difficult journey that they have to face. So it's different with suicidal ideation. Obviously suicidal ideation is very common, but suicide attempt is something to really screen for, be careful of.
It's important to note there, Alana, isn't it, that it's not so much that the medicine itself is the risk. It's the failure to contain, hold and integrate the medicine, which causes the problems, even as you say, in these kind of community uses. The problems that we get with harm reduction is not people's experience of the medicine per se, it's the experience of integrating the medicine, the way in which they take it, the setting that they've taken it in, the conditions, the relationships around them, and then what happens to them as the medicine is dissipating from their system, what then happens. And that's really where, the harm reduction interventions sort of happen, because you're looking at problematic integration, problematic preparation, and problematic setting. It's really not a problem of the medicine per se.
Yeah, and just also the same applies for a current domestic violence situation. It's quite risky to go into altered state work open up your mind, your body, your spirit, and then to return home to, an abuser or an abusive family. So that's something that's screened for in all kind of contexts. What would our comment be on people trying to self-administer and self-healing these use of substances? Taking the therapy seriously, but alone. So I guess we can individually speak to that. We maybe come from different perspectives. So I work, very much an advocate for the clinical space, for harm reduction, intentional recreational medicine, and also, a big, reverence and respect for shamanic and ceremonial work. But I guess if someone is going to take the medicine alone, there is ways that can be, there's checks that can be put in place. They can have therapy before, they can have therapy after, they can have support people to call, they can have done, harm reduction programs and built up their internal, I guess, metacognitive capacities to be able to hold that space. But it's not the first recommendation, but for some people in the community, that has been what they've needed at that time. So just acknowledging, all those methodologies, but safety is the key.
Because medicine's about deconstructing and reformation, human beings become who we are through our relationships, through the presence of another, the attunement of another, if we've got good people in our lives. So taking medicine alone can lead to some problems if there's not someone there in relationship. It's a really important kind of feature that we have another human being available to us, not that we would encourage offline use.
I think it's gone quick.
Lovely. Thanks, everyone.
Thanks so much for your time today.
Hope to see you around sometime.
Thanks, everyone.